All right, everybody, thank you for joining us today. Today we have Dr. Gutierrez hanging out with us, and she is going to give us an education in all things long COVID and post-acute sequelae of SARS-CoV-2, because I need to learn about this. And I figure there's no better person to reach out to than who I consider to be probably the foremost expert in our country as far as taking care of these patients. So Dr. Gutierrez, thank you for joining us today.
Yeah, thank you for having me.
And so I know that you've been very vocal and in terms of, caring for these patients, setting up a clinic, I believe over a year ago at this point, to be able to help these patients as they're out, recovering from the acute exacerbations of COVID and then figuring out how to help them. So can you just maybe start with we'll start with maybe a definition of long COVID or whichever terminology you prefer, and then kind of go from there.
Yeah, so I think there's probably three best terms to use right now. So one is either post-COVID conditions. That's kind of what the CDC is calling it. Then there's also the post-acute sequela of SARS-CoV-2 or PASC. Then there's long COVID. So I think any of those can kind of be used interchangeably. I think of where you go for your definition, you might read something a little bit differently. So there is a definition where it's kind of like more than 4 weeks after having COVID and you continue to have symptoms. So that's kind of one of the first traditional definitions of PASC. Then the World Health Organization came out more recently saying that it has to be 2 months afterwards. So I think overall, and we're still learning about the details of everything. It's just, you got COVID, usually nowadays we have a test. So, you had COVID back early in the pandemic when it was like March 2020, the vast majority of people there was not testing for. And so there's usually, so in that case, you had suspected COVID and then you continue to have symptoms for at least a month or more afterwards.
Yeah, and I think what you brought up probably plays into something that's a little bit more recent. I think it was JAMA that just published an article looking at post-COVID or I think they called it long COVID in their study, but saying that the only thing that was predictive of patients who having any symptoms was, a positive COVID test and then the anosmia that was associated with it. And they found no other correlations for those patients, which I think was really challenging because at least some of the interpretations that I've read, and I believe it was just published yesterday, so it's early in terms of when what the people are inferring from it. But there's a lot of discussion that there's a lot of people that are claiming symptoms of long COVID, but that don't have evidence that they were ever infected by COVID. But as you said, early on, especially here in the United States, the first 3 or 4 months of the pandemic, very few people were getting tested, and it was all kind of suspected COVID.
Yeah, and I think that's something that I've already seen kind of the Twitterverse talk about, the long COVID Twitterverse saying, at the beginning, there were so few people who actually were able to get tested in the, single digits percentile. And so how do we really know?
Yeah.
But I haven't read the full study yet, but that is kind of what I know is true. And then the rumblings from the long COVID world.
Got it. Well, so when you're talking about patients continuing to have symptoms, 30, 60, 90 days afterwards, what are the common symptoms that we're seeing affecting these patients?
So there was a pretty good systematic review that came out in one of the Nature scientific reports they looked at multiple studies across what's come out and saying, what are the top symptoms of long COVID? And so the most common ones they found were fatigue, was like 58% of people, headache, attention disorder, hair loss, and dyspnea. And then there was 50 other symptoms. So 55 symptoms in at least this systematic review that patients can have after having COVID. And I will tell you, it is very broad and it's very vast, and every patient kind of presents a different constellation of little symptoms that they have. And I tell people it's also very much the Corona coaster, because it's up and down with how they have some flares and exacerbations, and they might have some time of feeling good, and then their symptoms come back. But it really affects all types of symptoms, all types of systems as well. And then I think we're still also learning the phenotypes of this disease, that we still need to find a good way to categorize and do this research, because it's not the traditional PICS, like the post-intensive care syndrome, which we expected to see, patients being severely affected in the hospital and having post-intensive care syndrome, which we've seen before. But this is something that's different too, for patients who were not even hospitalized and had mild to moderate disease, but continue to have symptoms.
Yeah. There's been a lot of ranges of prevalence that have been published over time. I mean, early on, especially when they were utilizing patients that were, only ICU hospitalized, there were some numbers as high as 70, 80%. And I think I've seen papers quoted as low as, 10 to 20%. As you're seeing patients and you've been, treating this population for as long as anybody has at this point, what are you quoting as the prevalence and kind of seeing as that kind of population that you're treating?
Yeah, I think you're exactly right in how you're seeing it, that patients who are hospitalized, the data shows, 75, 76%, patients who weren't 10 to 30% type. But it's hard to know because I'm not seeing everyone. I'm seeing the ones who have the complaints. And I would say about 3/4 of my patients are people who were never hospitalized. Of course, most people are not hospitalized when they get COVID. But I am definitely seeing it's happening. I would say maybe overall it is closer to 20%.
Got it. Well, so maybe we can take a step back and say, I would love to know what your clinic actually looks like, when you've kind of set this up. And I do want to get into a little bit more of the nitty gritty in terms of COVID, but just because you brought it up, and your patient population being 75% not hospitalized was actually not what I was expecting you to say. So can you tell me a little bit about what your clinic is like, and where these patients are coming from, and how they're finding their way to you?
Okay. Our clinic officially opened in August 2020, and some of it came out of, seeing what was happening in other countries and knowing that patients were being affected very severely. I set this up thinking this was going to be, again, more severe type patients, but then they started having patients with these ongoing symptoms. And there was groups that came out online and calling themselves long haulers and survivor corps. And, so I said, I know I'm in San Antonio, Texas. This is the largest majority minority city in the country, a lot of Latinos, Latinx population here. And so knowing that population was also being disproportionately affected by COVID, more cases, more morbidity, more mortality, then there was going to be a need for rehab services to address this and for COVID recovery clinic. And so hence we came up with our clinic, and we have two clinics, one that's kind of at our med school UT Health Clinic, and the other one that's in our hospital affiliate, University Health, who kind of is able to serve patients who are traditionally more underserved and have Medicaid or don't have insurance, so that we could see all types of people with different social determinants of health and make sure that they have access to care and to services. And so I will tell you, we got a lot of media attention. We had, when they were doing screens of patients who had been positive, they'd call in on people a month later. How are you feeling? Are you still feeling bad? Some of them were referred to clinic that way. Some saw it on the news, and it just it's a very, very busy clinic. I would say it still takes 3 months to get in at this point to our clinic. A lot of it is done on telemedicine, because at this point, some of these patients, they've seen their specialists, they've seen pulmonology, they've seen cardiology, they've seen their primary care doctor, they've kind of had the chest x-ray and maybe the echo and the EKG. And a lot of them have a lot of fatigue and ongoing symptoms. So a lot of the first visits that we do are on telemedicine, just to help patients have to not make that extra trip and get very fatigued with their trip. And we do, some systematic pre-intake for some of the patients. We have, a symptom review that we look at with the patients. We kind of talk about what their main symptoms are, according to a symptom screen, see how they're doing. And then there's a lot of physical exam you can do on telemedicine, believe it or not. Some people don't believe it, but there is a lot you can do to see all these patients. And then we make, depending on their symptoms or their syndrome or what kind of phenotype it is, we do different types of tests, orders, referrals, etc.
Wow, that's amazing. I mean, the fact to be able to set it up in such a short amount of time, and then have the ability to set it up in multiple different locations to be able to serve the population is pretty impressive overall. But so, anyways, getting back to the long COVID itself. I mean, are there specific risk factors for patients developing long COVID or being more predisposed to these types of symptoms?
So I think it's, again, different on what you will see in the literature. So there was another review where they looked at kind of all this data on long COVID patients. But again, most of the studies were done on patients who had been hospitalized. So if you look at that, then the majority is going to be men, because that's usually who had more severe disease. But if you probably look at my own clinic and a lot of the other, I'm a part of a PASC collaborative of different COVID recovery clinics across the country. And for the most part, since we're seeing some of the mild, moderate cases that were never hospitalized, and there's not as many studies done on them, then it is a vast majority of women in their 40s. It's kind of what's being seen. There's some thoughts with that on, is it immune? Is it inflammation? Is it, it's probably kind of a combination of both of those things. Yeah. Just, you think who gets immune disease, autoimmune disease is women usually in their 40s, and yeah, who's getting long COVID, kind of that same population as well.
Yeah. You kind of led me directly into where I was planning on taking next was, the thoughts and the theories on, why, the mechanism of action, what the pathophysiology of, long COVID is, and obviously, you brought up multiple times already that there's such a wide array of patients and so many different ways that they were initially affected with the acute infection. And so obviously that's going to play a role, but is, maybe take it a little bit farther in terms of what you're talking about with some of the autoimmune and inflammatory components that you were just discussing.
Right. So definitely there is inflammation, there is immune dysregulation as well. And then there is, is there some kind of viral persistence that we're still not quite finding yet? So those are probably the three main leading reasons for pathophysiology of what's going on. First, we know for sure when SARS-CoV comes into the body that there are post-inflammatory cytokines. And even though some patients have the major cytokine storm that are hospitalized that make them very severe, there's still mini cytokine storm that can happen in someone who is non-hospitalized, and changing some of our different, we're kind of learning more about immune types and what type of immune types are changing with different interleukins and mast cell activation, and that's happening inside the body with inflammation. And then there's, again, immune dysregulation with what's happening to T cells and B cells and different people. And that's like, I'm not on the best at explaining that. It's been a long time since I've taken immunology, but definitely the immune response is affected. And some patients are having positive autoantibodies where they're finding a good amount of autoantibodies in some patients, and some of them mean something and some of them mean, they may not have that disease, but there is more autoantibodies that they're finding. And then the other thing that they're saying is there's some type of viral persistence. So maybe not the active part of SARS-CoV-2, but is there something that's in the GI tract that's there, which they found on some kind of, biopsies. And so definitely more to come. Those are kind of some of the leading theories.
Yeah, no, I mean, I think it, for me as a physiatrist who tends to more towards chronic pain and pain pathologies, it's really interesting hearing a lot of these terms and the theories, because there's so many of the things that we see from other pain pathologies and pain disease processes, and obviously with the way that a lot of these patients are presenting, early on, a lot of the thought or the talk that I heard and people were presenting was, how long COVID was going to be, or was looking like, some of the chronic fatigue type syndromes with, and then also looking almost, fibromyalgia like, or with some evidence of the, rheumatologic type symptoms of autoimmunity. And so, as we're thinking about those kind of pain presentations, and maybe more specifically, the things that would generally show up in a physiatry office, what are some of those presentations that would be more likely to show up in, in the community physiatry office as opposed to, some of the academic centers like you're in?
Yeah, so interesting where you had talked about pain conditions, and one of the studies that had looked at immune-based predictions of patients with PASC and then who developed long COVID. A couple of things that they had was increased interferon gamma and interleukin-2. And if you look at some of the studies on failed back syndrome, some of those patients have increased interferon gamma as well. So pretty interesting that there's that tie-in with some of those inflammatory markers in chronic pain states. But in one of the largest studies that they looked at long COVID survivors, and it came out of the University of Indiana, and it was based on a lot of self-reported patients who were on one of the virtual groups, and they looked at them and asked what their symptoms were, and 26% of their symptoms had to do with pain and were pain-related symptoms. And most of those can be anything and everything that could come through a physiatrist's door or even a PCP's door. So anything from, I had some patients that had fibromyalgia, completely controlled, able to work, to fibromyalgia out of control. Everything I do, nothing that we can do can help them. I've had some patients who had, again, some kind of underlying little back pain, and then it just goes and just becomes this like intolerable severe back pain. I have patients who have cramps, patients with neuropathies, patients with muscle pains, patients with like chronic throat pain. I've had atypical facial pain, chronic migraines, migraine status, occipital neuralgias, burning in the chest that is not, that chest pressure. It's more like costochondritis and not, they've been ruled out for everything that's cardiac. So anything, everything, it just can cause, and you can see it coming through.
Yeah, I mean, with our patient base and our population, some of the things that we saw early on, and we're by no means a center for long COVID, or we're looking necessarily to reach out to that population, but with our patients that were already living with chronic pain syndromes, we saw a number of them have pain flares, as you were describing, where they were relatively well controlled. They had their regimen, whether it's medications or therapy or in the occasional injection, and then found their way into this completely uncontrolled pain state that was essentially just thrown off by being infected with COVID. And particularly in my patients, CRPS was one that I've seen a number of patients that have really kind of gone from holding things together, being relatively functional and things being relatively stable. I always use relatively with CRPS because it's always it's always relative. But then getting to this place where things are completely out of control and our normal tools that were working for that patient are not working anymore.
I have a question for you now, because there's been a few just kind of case studies, case series, really a few, where they're using stellate ganglion blocks to help with long COVID, because then they're thinking that there'd be a sympathetic overflow of part of this fight or flight. Have you done stellate ganglion blocks redone it on any of these CRPS patients, and has it helped?
I have not done a stellate ganglion block on any CRPS patient that was diagnosed with COVID or had a flare of symptoms. I have a couple of patients that have had lumbar sympathetic blocks, which, generally when we're thinking about a generalized state and reaching back to the PTSD literature, we're thinking of the stellate ganglion block as really being the one that's utilized for that patient population. But I have had a couple of patients that we've done lumbar sympathetic blocks on afterwards because they're lower extremity symptoms that didn't get as good of response as they had gotten previously. Not that they didn't work at all, but it wasn't quite as successful as they had been in the past. And
Yeah.
so, which, might lend to the theory that, that you just brought up of whether or not, even somebody with lower extremity symptoms primarily who now has this much more diffuse presentation, whether something like a stellate would be helpful for them. We have not explored that yet, but I have not read those studies. And so
So now we're coming up with a case series here we're going to work on together. I had a patient who had already had a spinal cord stimulator in, and they kind of adjusted that, and that helped her somewhat. And one person that newly got a spinal cord stimulator where it helped her as well. So yeah, neuromodulation, I think we're still all figuring that out.
Yeah. We have had to adjust some of and reprogram some of the patients that have stimulators in them that were, having increases in pain. And yes, similarly, we've had recapture of pain with the stimulators, at least in the handful of patients that I've seen with it. Yeah, I mean, I think those are some of the things that, as we're trying to see these patients or seeing these patients more often and trying to figure out how to help them, we're trying to figure out if those tools that we utilized for some of these other, pain states are going to be helpful for the patients that are unable to be helped by some of the more conservative options.
The other thing is we're seeing a lot of COVID headaches. And so that's something that also may come into the door of a pain doctor, physiatrist, neurologist, and they do have some kind of a review of what patients are more likely to get headaches. They're saying, people who'd had anosmia and ageusia. So you think like, okay, there is definitely some CNS involvement in some of these, review studies. It's men more than women. So a little bit different than what I'm seeing in just my general long COVID population, and people who had GI symptoms. So again, I think we learned so much more. There's so much like gut brain connection that we still learning of about our microbiome and our bodies. And so for these patients, one thing that I'm sending and working with my pain colleagues in doing SPG blocks for them to see, and it's been helpful in some of those patients that have gotten it.
Interesting.
Yeah, which we still like is the SPGs, both parasympathetic and sympathetic. What is it doing? So.
Yeah, no, it's interesting. One of the when as you start kind of going down, the rabbit hole, and this is so interesting to me. I keep wanting to go down the rabbit hole. I was trying to keep the conversation a little bit more generalized. But I mean, I think it is really interesting as you start to go down that rabbit hole and starting to think about all of the micro theories that are out there and how things are presenting. As you were talking about that, one of the things that came to mind is a conversation that me and some of our partners here have had multiple times, because some of the earliest referrals we were getting were for electrodiagnostic evaluations and thinking about some of the neuropathies that were happening, and then, thinking about, okay, is this truly a neuropathic problem? Is this a microvasculature problem? Is it some combination of both, and the way that it's presenting, small fiber neuropathy versus, I know that some of the early case reports, especially when they were talking about some of the larger neuropathies, people presenting with, either drop wrist or drop foot or things along those lines, there was a vascular component to them. But for people that are coming with, these small fiber neuropathies that I know that we have seen coming through and referred for electrodiagnostic evaluation, is which one is it more likely to be? Because obviously they have slightly different treatment options and theories behind what we're looking at to be able to help them. I don't know if you had any thoughts or
yes,
add on it.
Lots of thoughts. So I think you're right. At first, some of the data that was coming out was on the patients that were hospitalized, and these people were prone and they had a lot of edema, and they were poked and prodded and put in these positions that they had to be put in, like the swimmer's position when they were prone. And so they had a lot of injuries that are associated with their overlying edema and the compression mechanism. So it's mostly usually some type of compressive neuropathies in these patients. And then you saw again the traditional critical illness polyneuropathies and myopathies that you see in hospitalized patients. So then what do I start seeing in patients who are not hospitalized? And then probably one of the top referrals I make is to our electrodiagnostic lab to see our specialists, our PM&R specialists who do that. And I will tell you, we are getting tons of myopathies in patients who are not hospitalized, like inflammatory myopathies. And their patients, and that's one thing that we know, that there's ACE2 receptors in muscles as well. So, is there, some inflammation in the muscles related to their initial infection, and then they're at home, and then, they still continue to feel weak and their legs hurt. And it's all the typical stuff you'd expect to hear that you learn, like it's hard to do stairs. I have to push myself up when I sit. And then I have them do, and it's a validated exam on telemedicine, like a 5 times sit to stand, and they have difficulty with that, or it takes a long time. Then to me, that's like, oh, red flag, let's get them into the EMG lab. And then you still have some of the traditional, if someone seems like they have a neuropathy and they go to the EMG and their EMG is normal, then that's when, and they still have, atypical painful neuropathy, then I will send them to get the small fiber biopsy for that.
What have you seen from small fiber biopsies in this population? Have you actually had some interesting results?
Yeah, but only a couple that I've had that have had positive small fiber biopsies, and we just don't do it excessively here. Maybe that's that we don't like biopsy everyone. Some of them we just kind of try to treat symptomatically otherwise, and but we are seeing it some for sure, and it's very difficult to treat type of neuropathy, and so we're just, and it can be something that's seen a lot in the autonomic dysfunction. So the patients that have, POTS and autonomic dysfunction and dysautonomia, which a good amount of patients get, part of that syndrome can be small fiber neuropathy and these neuropathic pains.
Yeah, that's super, super interesting to be able to maybe pull back a little bit. And so let's kind of think about the average person who's probably listening to this. So medical student, resident, maybe some fellows, or people that are—
You're doing great. You're really smart.
You guys are doing great. Or even people that are maybe in occupational medicine clinics, because I know that now this is showing up in OcMed clinics where, that maybe they don't have some of the academic resources of a UT. Where should they start? Like if you're starting to see these patients, they're coming in, they're starting, they're patients that may or may not have a clinical diagnosis of COVID, but definitely feel like they had a diagnosis of COVID. They're 2 or 3 months out down the road and they're having these persistent symptoms. Like where is a very practical place for them to be able to start with these patients?
Okay, so probably the most important thing to do is screening like I said, the number one symptom is going to be fatigue, and screening these patients for fatigue. With that, there's formal scales. There's like PROMIS fatigue scale. We have, sometimes I just use a 0 to 10 fatigue scale that I ask them about every time. 0 is you feel no fatigue. 10 is you can't get out of bed, and how are you doing on average or in the last day. And then the other thing to screen for is post-exertional malaise. So that's something that's very important to look at, because this is something that patients who have long COVID will have, and patients who have the chronic fatigue, CFS-ME, this population or that subtype of fatigue has a lot of post-exertional malaise. So what that is, means like someone, they may feel okay, or they try to do something that they would otherwise be able to do, and then they adjust afterwards, it knocks them out. And whether that be, right after it, they have to sleep and they're totally exhausted, or the next day they wake up and they can't get out of bed because it just knocked them out that bad. And that's where patients are really impacted by long COVID, is this post-exertional malaise. The other thing is we have a paper that came out in the PM&R journal that's part of our consensus group that came out with initial consensus guidelines for fatigue. So, I definitely think that paper is excellent, and it talks a lot about fatigue, about what, how to screen someone, what assessments should make, what workups should be made, and then how to educate and treat these patients And so it's a great guideline that's available to anyone to say, okay, this is, is it organic? Is it more of a chronic fatigue type picture, which those patients, you can't exercise them. That's not the answer, because exercise, like I said, makes them worse. Work can make them worse. And it's not the traditional like graded exercise therapy. That's the opposite of what those patients need.
Got it. No, that's a great differentiation to make for everybody. And that paper will be linked in the show notes, so that way you guys have easy access to it and go read it, because it is a very good one. And so, you're very good at answering the questions that I had next. And so one of the things I was going to ask was, what are the things that you have to specifically be looking out for? And I think that's a good example of one, right? Understanding the difference between, somebody who is showing these post-exertional fatigue symptoms, versus somebody who's not, and being able to direct them more.
Right. And I don't think we have all the like perfect answers yet. Some people are just debilitated. It may just need a little exercise and more extra, therapy, and getting them to get more activity might be great. And some people that would just knock them out and make them actually be worse. So you really kind of have to know, like, what are the diagnostic criteria for ME/CFS, which is usually like, okay, substantial impact to their activities of daily living, the post-exertional malaise and unrefreshing sleep. So these patients just their insomnia is bad. They can't ever get refreshing sleep. And then usually they either have cognitive impairment or some type of autonomic dysfunction or orthostatic intolerance, one of those two with the other symptoms. And what's tough is a lot of their testing may be otherwise normal when you check their labs and checked everything else. So, but there are diagnostic criteria, and figuring out those patients need something way different than ones who are just a little debilitated and could benefit from structured exercise. And these people really have to learn pacing and energy conservation and prioritizing what they have to do to, just get through life.
Yeah. No, it's so fascinating. As you were saying all of that, two things really popped in my mind. One was, man, it sounds a whole lot like so many of our chronic pain syndromes, which you already brought up. The other thing that came to mind was post-polio syndrome as something that's, kind of, when you start talking about the pacing and being able to, really learn how to adapt your life to these symptoms, just as another corollary. Sorry, that my mind works in weird ways, and I kind of have this flight of ideas. And so, sorry, I just felt like throwing that out there.
And that's part of the reason also why I did this clinic, and was because I knew that actually physiatry came out of post-polio and patients, needing iron lungs, and them creating facilities for patients who had these new disabilities. And then once they finally got a vaccine, which was not as quick or wonderful as we got ours, but then they eradicated polio, that those became the rehab hospitals and they became the rehab doctors. But now we're seeing these patients with the effects later with their post-polio syndrome. And, what are we going to see later with COVID-19?
Yeah. I mean, it's a fascinating question, because I know, I've read some, opinions where they were talking about, some of the past flu pandemics, and that really the entire toll on the health system at large, but even on patients, wasn't known for years. And, the fact that things are already, so impacted for these patients, and there's already such a high number of these patients that are, having symptoms in, a few months to, maybe at this point, you have some patients that are a year out for this, what's going to happen 3, 5, 10 years from now.
Right. There's some diseases where like just something lie dormant in the brain or in your, and right. So,
yeah. I mean,
scary.
Yeah, a lot, far too theoretical for what we're talking about today. But
Right.
if we're going to leave our listeners with maybe 2 of the best takeaways that you have, or 3 if you have, I don't know if you have some that you've used before, but what are the key things that you want to make sure that everybody leaves our discussion on long COVID with, as they kind of go out into the world and potentially see these patients, or talk to other people that are seeing these patients?
Number 1 is believe patients, believe them these are people who are suffering, and yes, despite some tests that might be normal, that doesn't mean that they don't have true long COVID disease, brain fog, cognitive dysfunction. No, there's only so much we know and or that we could research that we can test right now. And so I think patients want to be heard. They want to know that their symptoms and what they're having is validated. They, you know, when I see patients, they might say, I have this symptom, it's still going on. I'll say, oh, I have another patient with that. Oh, okay, I'm not making it up. Or I'm losing my hair. If that's like the fourth most common thing, then they feel like they're not alone in this and that they feel validated. Not to blow it off, you know, and say, oh, it's mental, oh, you're depressed, you're anxious, you're sad. And we kind of have a tendency to do that in some chronic states. And it's probably the depression and sadness. First, we know neuroinflammation can cause psychiatric disease, and there is neuroinflammation after COVID. And then also it's probably an effect of being blown off and being gaslit and everything else that they probably feel that. It's an adjustment disorder type of thing because no one's listening to them. Yeah. And then probably the last thing I would say is, or I guess these patients need time. You know, these are not short visits. These are not 10-minute visits. These are, you know, 45-minute visits where I'm listening to patients and giving them, providing them education about it.
I think those are two amazing things to leave with. I mean, it is amazing, you know, and obviously as a person who my day job is treating patients with chronic pain, like it's amazing how many people don't take the default of believing the patient first in all things, right? And obviously I see it all the time for patients that have been living, you know, with pain for years and years. Now we're seeing it with patients that are, you know, continuing to have these symptoms, you know, that after a COVID infection. But it is, you know, kind of coming back to those basics of what brought you into medicine in the first place, right? Spend time with the patient, listen to them, believe them, try your best to help. It's amazing how that just kind of keeps working.
To add to that is look at social determinants of health. We sometimes don't do a great job of that, but in trying to, you know, make accommodations so patients can have the best outcomes.
Those are amazing, amazing things to leave everybody with. Dr. Gutierrez, thank you so much for your time. Hopefully people learned a ton, and if they want to reach out to you or kind of learn more from you or about you, where would you send everybody to be able to do any of that?
I guess you can follow me on Twitter. I'm at MV Gutierrez MD. So MVGutierrez MD. I have an Instagram that's Monica V Gutierrez, and you know, usually Twitter, I'll put information about long COVID, and sometimes in my Instagram stories we'll have that type of information as well. And then of course, if anyone needs to reach out for me, they can find my email online. So
awesome. Well, thank you so much for spending time with us today. I really do appreciate it. I found a lot of value out of this. I learned a ton, and I hope everybody else out there did too. Thank you again.
Thank you for having me.